Thanks, everyone. Thanks, Dr. Shim. That was a good introduction to potential uses for my talk as well. And I agree with some of your biases as well, and we'll talk about it. So I do some work with Action. I help teach some of their courses, but nothing to influence this. As far as dorsal shearing injuries of the hand and wrist, for anybody that's around big trauma centers and roadways where people go too fast, you'll see a variety of these. We tend to see one every few months. They're pretty daunting injuries, as we all know. It's daunting in itself just to get it closed. It's even more daunting and difficult to really get a good result in terms of function, secondary to adhesions and reconstructions that need to be done. It's really a particularly unique and challenging type of mangling hand extremity for some aspects that we'll talk about. And as I mentioned, they're often associated with high-speed motor vehicle accidents where someone has their arm out and it shears off against the road, and it clearly has extensive tissue loss of composite levels. And here's just a few of some recent ones that we've seen. That's not advancing. The goals of care for this, we certainly want to salvage the hand. We want to restore and or maintain whatever function is there. The challenges are everything that's missing and that needs to be replaced and still work. There could be bony skeletal injuries. There could be bone loss. There could be joint instability, ligamentous injury, just true bone loss of articular surfaces. The extensor tendons are gone, and with that, the particular gliding plane that allows them to function and not have extrinsic contracture of the digits. And then on top of that is the soft tissue envelope and how that's going to be contoured, not only to allow that gliding surface, but also to allow aesthetically pleasing result for the patient and for whatever activities they need to perform. I would definitely remind everyone that with high energy trauma, we really need to respect the ATLS and trauma protocols. We need to cooperate with our trauma colleagues. They need primary, secondary, and tertiary surveys by the trauma team. These are often associated with solid organ injuries, whether it's liver or spleen, head injuries, and certainly the upper extremity and thereby the lower extremity as well can take kind of a back seat until more pressing issues are dealt with. The standard workup for everything we know is physical exam and radiographs. We want to evaluate, is it sensate, is it vascularized? In terms of what you do for these patients, hand dominance and occupation, even age, or more importantly, their independence and what they're using hand for is important in terms of how much of a functional result do you need in terms of flexion, extension of the digits, or is it really just going to be a helper hand? Has there been concomitant injury of brachial plexus or traumatic brain injury that's essentially going to leave them with a non-functional limb in the first place that can't even power the extensors anymore? What's interesting about these injuries, they don't really require any microsurgical intervention in the night of injury, and that's kind of the challenge with it, where it's not a quick fix. It's not something you're going to be able to take care of on the day of injury. It's going to take multiple stages from here. The major vessels and the nerves are on the palmar side, and they're often spared. It's everything just dorsal to it. The first step is a very, very thorough debridement, as Dr. Chim had alluded to in some of his pictures. You got to get out everything that's dead, everything that's contaminated. And if you don't, you're just setting yourself up for failure because of all the stages of reconstruction, all the hardware, all the grafts that are going to go into this. A very thorough and careful excisional debridement is required, and this can take maybe 45 minutes, an hour alone. We should use it all, whatever is available to us in different hospital systems. For sharp debridement, if you have a hydro dissection system, that could be quite helpful, or just use your scalpel, scissors, rongeurs. Definitely expect blood loss along with this. My preference is to do this off tourniquet, so I expect it to be bloody. I want to make sure that everything's gone that's contaminated and or dead. Doug Hanel teaches this so well from University of Washington, that you should debride everything but the white stuff, unless you really need to take the white stuff. And that certainly referring to bone and tendon and even nerve, if it truly is ultimately contaminated and dead. And these can take multiple stages of debridement. It's not uncommon that I'll take it back for a second look or a third look, particularly depending on what they went through. If it's a farm-related injury, if they rolled over into a field, I often just explain to the trainees and to the patient, just think about what's in that field. So if there's horses and cows, we all know what they do in that field, and that's what needs to get out of that wound. And you can see in this picture, grossly contaminated wounds. And after you spend some time with it, you really start looking at it, and reminds me of the Netter's anatomy book, and just the slice and kind of what the injury is. It's this tangential shear, and everything's missing from that level up, like it's a CT scan. I just want to comment on negative pressure wound therapy. Although there's always concerns of desiccation of the bone and tendons that are there, particularly if nerves exposed, and vessels, but I do think it's useful. I like negative pressure wound therapy, whatever system you have. For those that have never seen this technique or don't know about it, I highly recommend it. It really changed my practice, and everyone I've shown it to seems to find it very similarly beneficial. So we all know it's very hard to get a seal around the web spaces of the fingers with the strips of what you typically use. But what you can do is just staple the sponge directly to the wound. You can take a surgical glove, a sterile glove in the operating room. You just put it on, cut the fingertips off, and put the lily pad device directly to a hole in the glove. And when the negative pressure turns on, it basically sucks the web spaces of the glove into the commissures, sealing it down. And this has worked tremendously well. I did not come up with this technique. Here's the paper that I think is the first reference of it. You can even use it. That picture's from the top right is from their article. You can put it over X fixes if you put enough foam on top of it. I've used it for other mangling extremities like the bottom right, where it's just difficult to get a good seal with fingers missing, and it works very, very well. It does get a little macerated, but it really just it's more of a look to it than an actual problem. In terms of bony stabilization, once the wound bed is deemed appropriate, we'll start moving on to this. Certainly external fixators will be quite helpful, and sometimes it's not even enough with this wound that's in the top right. There's so much instability, there's so much soft tissue loss of ligamentous retaining structures. The wrist just sag down. So in addition to it, multiple pins are placed. And I'll remind people about the use of cement for spacing to keep your length in terms of what secondary reconstructions you'll do later, whether it's bone grafting, you're going to go to arthrodesis, or you're going to put a vascularized joint in if it's MP, PIP, or you're going to go to arthroplasty with this. We really should be mindful and thoughtful in terms of pin placement. As with the previous lecture, there's external fixators that are going on, and we have to work free flaps around it. We certainly don't want to cause secondary injury to anything that's there. So we really have to be mindful, not at the time of this surgery, but what's the next surgery and the surgery after going to include. We all know the reconstructive ladder. We certainly take the reconstructive elevator more times than that. Ultimately, we want vascularized soft tissue resurfacing of this. That not only provides stable coverage to allow for healing of this, but ultimately we want restoration of a gliding bed for extensor function so that they can have flexion of their digits without extrinsic contracture. Multiple options exist, and this talk will not be able to go over everything. And there's some very talented people on this webinar right now. Just to keep in mind that A lot of these have ultimately been eliminated based on the type of injury and the zone of injury. There's a lot of adjacent trauma, and the typical pedicle regional flaps, which can be used for such as malignant surgery, secondary malignant defects, are no longer in play, like reverse radioform flaps and other perforator flaps in the extremity. A lot of composite tissue flaps have been described. You can harvest the dorsalis pedis with tendon to reconstruct, ALT with fascia, with fascial autografts for the same purpose. If there's bony defects, the serratus plus minus LD with scapula can be harvested. There's daisy chaining and flow through flaps. A lot of options exist for this. One thing to keep in mind is that that argument of fascia cutaneous versus muscle flap. So I agree with Dr. Chim that I've been trained that way as well, that muscle flaps offer robust vascularity. Particularly, they're very good at contouring and filling in little crevices around plates, hardware, and bone losses. That being said, with these planned staged reconstructions, it can be difficult to raise them later. So for me, in this area, if I know I'm coming back for tendon or joint reconstructions, I typically will go with fascia cutaneous, but it depends on what is there in the first place. In the Western world, we have to keep in mind that a lot of these fascia cutaneous flaps can be rather bulky. You can see in these pictures here, this was actually a pedicle groin flap that came for secondary reconstructions to our center. You could see it's rather large. They even had difficulty closing the flap and had to skin graft the ulnar aspect of it. This is after liposuction of the flap. You could see really how much you can get rid of and then get a better contour with it. If you like using the skip flap for that thinner purpose, the fascia cutaneous, one pearl to keep in mind would be to probably harvest from the contralateral side, so that if you have a problem, you at least have your ipsilateral pedicle groin flap as your bailout later. The extensor tendon reconstruction can be rather challenging. The primary challenge is that the loss of the substance is the loss of the substance, and how are you going to replace the extensor tendons? And sure, there's plenty of options and where you can go. It's compounded by the fact that there's going to be significant scar formation. There's going to be a lot of adhesions to these extensor grafts from your flap down to the bony surfaces, and you're going to have a loss of a gliding surface. A lot of options exist on how you can do this. If you have some extensors that still remain, certainly side to side tenodesis is very helpful to power the extensor tendons from the distal to whatever side extensors that are still there. It's been described as what can be done in like the spinal cord population, a tenodesis of the terminal extensors just to the dorsal radius or carpus, almost as a tenodesis effect, a passive effect to keep to extend the digits. Free tendon grafts are a great option, but you have to think about at what time are you going to be considering these. If you do it in the first stage, the rehabilitation may be complicated as you're trying to limit kind of motion in that area as the free flap is healing. And the same thing if you're doing any type of joint reconstruction, where it can be rather counterproductive to have motion at the same time as whatever reconstructive goal you have. Our preferred method is to put in extensor silastic implants. So these are what are typically referred to as rods. The namesake, or the one of the original founders of the Philadelphia Hand Center was Jim Hunter, and we all know about what's referred to as the Hunter rod. Just as a tidbit, he hated the reference of a rod because a rod is inflexible. He preferred a flexible silicone implant as the name. And if you don't know, although these are typically associated with staged flexor tendon reconstruction, Jim Hunter actually first described it in 1965 to reconstruct an extensor tendon of an index finger, and has since been used in multiple modalities. So similar to the flexors, this implant is sewn to the distal end of the tendon. It gets passed underneath the flap and into the forearm wherever you want it to be. Are you going to go to the native extensor tendons in the forearm if you have them, or are you going to go towards some sort of tendon transfer like an FCR, FCU, and you can pre-place them? It allows for a pseudo sheath to form, which can allow for that gliding surface and allows for passive motion as well. These devices that are there can be split into multiple configurations, typically a Y. You can try to do 3, but the Dacron inside starts fraying and it can be rather difficult and rather thin. The second stage involves passing tendon grafts, just like you would do for a stage flexor tendon, pass it from one way to the other along these pseudo sheath tunnels, and then the typical pulver-taft weave or side-to-side distally and proximally, depending on what you want to power it. And you can see here, this with a lot of hardware, this was with a latissimus dorsi. These were going to be passed underneath the muscle. So a latissimus dorsi muscle was used. You can see on the X-ray, the outline, the radio opacity of the implants and where they are. Post-operative rehabilitation, I think this is probably one of the most challenging aspects of the reconstruction, is how to preserve motion. And this is something that often gets overlooked because we're so concerned about everything else like the flap. But ultimately, it should be utilized throughout all phases of reconstruction. It's absolutely paramount to a successful outcome. If you ignore it, you will end up with stiffness and contractures and need secondary procedures to release this and ultimately kind of spoil your potentially great reconstruction. It's very challenging for the patient. They're in a bad place. They have a lot of pain, a lot of swelling, a lot of mental depression going on based on what their injury is. And it's challenging for the surgeon because we're afraid to do too much in that initial perioperative period. But I implore you to really do it. In terms of the unaffected digits, they start right away within a day or two after the injury. We should keep those unaffected digits moving. That is terrible that a non-injured digit ends up becoming stiff after these injuries. For the injured digits, certainly by 2 weeks, if not sooner, if we can get some passive motion working through that with joint mobilizations and the glides, whether it's with implants or with native tendon or tendon grafts. In terms of additional stage reconstructions, these typically can be performed as soon as there's tissue equilibrium, and that can be variable, but typically around 2 months, and every patient matters, and certainly things can change that. I just want to go through a case and I'll end it with that, putting this all together. This was a 19-year-old male who was transferred. He was an unrestrained driver, high-speed motor vehicle accident. His arm was out the window, driving too fast on a rainy night. And when car rolled over multiple times, and he initially was treated in an outside hospital. As mentioned before, trauma survey, he did have a splenic laceration, had to be taken to the angio suite for embolization of that. He was initially debrided there and then transferred pressure wound therapy dressing in place. So this is after the first and then the second debridement. You can see again the glove being used, which is rather helpful, keeps the swelling down, keeps kind of all the wound margins in place as you continue to debride this. This gentleman went under 2 additional debridements just based on his length of transfer. It was very rainy that night and they couldn't fly him. So it was, I think, over 24 hours to 36 hours before he had a good debridement. So ultimately, his next stage of reconstruction was going to be resurfacing with the ALT flap, fasciocutaneous, with skin grafting elsewhere. You can see in the x-rays, he had loss of his metacarpal head to the index through small finger. These are cement spacers that are being used to plan for eventual arthroplasty for this. 2 months later, the flap is viable, it's well contoured, his skin grafts have healed. We go back, we lift the distal end of the fasciocutaneous flap, we remove the silica, we remove the cement spacers, we put in silicone arthroplasties for the MP joints, we pass under the flexible silastic implants for extensor tendon reconstruction. He begins passive range of motion for the joints as well as the tendon reconstruction. Of course, for this, I forgot pictures of this, so that's a big forehead smack. But at 4 months, we do bilateral palmaris longus grafts. We power it through the FCR because of a lot of adhesions and going onto the skin grafts on the dorsal forearm. I felt that that was best. This is him 2.5 years later. This was a kid who, for a lot of his postoperative recovery, he was more interested in just playing video games and smoking marijuana, really didn't have a direction. But eventually he realized that his hand was pretty functional, and he went to work as a window washer now.
Good. And then you can put that down. Let me see, just open the hand and close. Good. Great.
So overall, these are, as with everything, usually a team approach. And I do thank Matt Wilson, who's one of my colleagues here. We do a lot of the complex reconstructions with. But ultimately, I'll leave it with that. I'll take any questions at the end. But these can be, again, very challenging cases, but very rewarding in the end. There's a lot of steps along the way that we can get tripped up on. And hopefully this presentation brought some of that to light.